Patent ductus arteriosus, that is, there is a ductus arteriosus will be patent between the pulmonary artery and the descending aorta. So usually this is present so that the lung is bypassed in case of fetus, but this is persistent. And patent ductus arteriosus, see, the ductus arteriosus usually functionally closes after 10 to 15 hours of birth, anatomically around 21 days, and it becomes ligamentum arteriosum. If this doesn't become, that is when the problem arises. So if you can see it from the right ventricle, the pulmonary veins will go into the lungs, which then oxygenizes. The oxygenated blood gets oxygenized, and then it comes back to the left atrium as pulmonary vein. But then what happens is that pulmonary artery will shunt the lungs because the patient is not, the fetus will not be breathing in utero, and it will just connect it into the aorta. And this is persistent after 10 to 21 days in case of the child. Now what happens is that okay, the main thing what happens is that you will develop the same thing, CHF between 2 to 6 weeks of age, and the clue is you'll have a collapsing carotid and a dancing carotid, which will be similar to that of AR. Now in case of heart sounds, S1 will be masked because of the continuous murmur, apex will be normal, S2 you'll have a paradoxical split. Now what happens is that aorta will close earlier because pulmonary takes a longer time to close. So S2 is narrow, and since you have CHF, you will have S3. Obviously, you have continuous murmur at the left infraclavicular or suprasternal edge of the scapula. All these areas, it's all the same place, right? This is the infraclavicular, suprasternal, or you'll have the scapula. Everything, and also you'll have a flow murmur similar to that of the ASC, ejection systolic murmur at pulmonary, diastolic at tricuspid area, and X-ray you'll have cardiomegaly, plethora, and all that, and you'll have a deep Q wave at V5 and V6. Now what happens is that the one thing to important is that they develop Eisenmenger syndrome early. Eisenmenger syndrome is that all whatever red is left to right shunt. Now what happens as years pass by, it becomes a right to left shunt. So what the CHF will disappear and the cyanosis will start presenting. See, it's a acyanotic heart disease, then later on they will present with cyanosis. This is only Eisenmenger syndrome because it becomes an opposite shunt. Also they'll have pulmonary hypertension, vascular changes, pulmonary vascular changes. So Eisenmenger in PDA will develop around 20 years, VSD is around 30 to 40, and ASD 40 to 50 years. Alright, so what is a differential diagnosis? Differential cyanosis will be present. That is, in upper limb will have normal saturation and there will be no cyanosis. In lower limb, because of decreased saturation, you will have cyanosis. Now you can treat them medically by giving ibuprofen, that is PGE1 antagonist. Drug of choice is IV paracetamol. In the term baby, small asymptomatic or a large PDA at around 1 year, you can do small asymptomatic. You don't need to do much thing. You can just give ibuprofen and paracetamol. Large PDA at around 1 year, you do double ligation at both the ends between the pulmonary and the aortic end. And the medium sized PDA, you give a device closure. Now differential cyanosis, how do we say that? Is like preductal O2, that is around the upper limb you will have a normal oxygenation. Postductal you will have a low oxygenation.